Gaining access. So it's I think today I think you guys pretty much knew that most of the peripheral interventions are done from the femoral axis. I know pedal axis has gained some popularity, but I think I want you guys to leave here thinking that femoral axis is the primary axis as of now. And closure is definitely something which is very important. You can have a very successful vascular intervention done, but if you anything happens to the axis site, then you will end up pretty much having the same issues again, right? You will end up with the vascular complications. Patient is not going to be happy about it. So, it's getting an access and taking care of the access at the end of the intervention is as important as the intervention itself. I'm pretty sure all of you guys, even if you're cardiology fellows, interventional fellows, vascular surgeons, IR guys, all of you guys probably might have seen this because we don't just use femoral access for just doing peripheral interventions. We do it for iliac interventions. We're doing for carotid interventions, subclavians. We do it for mesenteric, renals, uterine embolizations. I think femoral access is the key access for a lot of stuff. So at this point, so let's talk about it, complications and challenges, how to get accesses, what are different ways of getting accesses. And we'll talk some about the Proglide family because it's sponsored by Abbott at the end of the day, so I have to talk about it. But that's not only that, but it's my favorite device. I don't pretty much use any other closure device except that. Actually, I really like the device a lot. So again, I don't think this needs any more reiteration than what you guys already know. Hematomas, pseudos, AV fistulas, bleeding sites. I think this is the reason why pedal access became so popular because a lot of endovascular guys who are doing endovascular from all fields, especially if they're doing outpatient in outpatient setting, in OBL setting, ASC setting, they don't want to deal with any femoral access complications because that delays the patient stay, that requires transfer to the hospital admissions, reportable through the state. I think that's why they are probably going through pedal first. What I'm trying to say is I don't know if it's right or wrong, as Dr. Krishnan was saying, there's a lot of gray zones here, but foot is our target organ. You can't access a target organ unless it's definitely necessary to access a target organ. So femoral access still stands to be the primary access point. So you guys have to know how to deal with it. And you can successfully deal with it. I think the complication rates have gone down significantly over time, especially now that we have better ways of accessing femoral arteries. Vascular closure devices, at the end of the day, you guys have to remember, you are paying money. If you are using this device, you're paying money to get a complication. So don't use it unless you're definitely comfortable with it. So there is no manual pull is definitely an option at the end of the day. You know that it can be done, especially if you're using a 6 French or a 5 French device, sheets in. So use it when you're comfortable, use it in the right manner, exactly when it's needed to be used. You don't want to do another intervention at the same time. Ultrasound guided access. I think this is something definitely to be talked about. I think has gained a lot of popularity in the recent times, especially now that people are very comfortable with ultrasound guided pedal accesses, ultrasound guided. So there are a couple of studies which have clearly shown that ultrasound guided access is definitely better, reduces the amount of complications. The closure rates are almost 98%. You can actually close the vessel if you get ultrasound guided access because you can see the calcified plaque, you can see the heterogeneous plaque, get away from the access, away from the plaque, and do it. Couple of things to worry about when you get ultrasound guided access. If you're not very experienced in ultrasound guided access, you can get a very high access. That's the most common problem by using ultrasound. High accesses, now you end up very close to the inferior epigastric, and that's where the perforation rates go in. And then you will end up not closing it because you can't see inferior epigastric on the ultrasound unless you're really good at it. So always aim low, use the fluoro. If you really ask me, whenever you're doing ultrasound guided access, fluoro once. Check your access point and then access it. That I think it helps a lot. It's just a couple of milligray of radiation, which is not a big deal. Again, lot of studies have been out there which have clearly shown fluoroscopic guidance has reduced it, ultrasound guided access has reduced it, But definitely ultrasound guided access is probably the most popular and reduce the complications a lot. How many of you here use ultrasound guidance femoral access? Wow. Jeez. Very good. Very nice. I didn't realize it was that popular. But fellows, our fellow programs, we just see the artery and just stick it. Sinai, we don't have time to get ultrasound into it. But yes, we do use it. Um, the benefits of it, of course, you know exactly where the bifurcation is. You can go above the level of the bifurcation. That's the biggest advantage. And the other advantage is, especially if you're doing large bore access, ultrasound guided access makes a huge difference. A lot of programs don't use it. They go by the fluoro because they already have CAT scan. That's TAVR, guys. But if you're using for AAA, if you guys are doing AAA, like I do for AAA, I definitely get ultrasound guided access because I see where the plaque is. I want to make sure I go away from the plaque. I can close it. If I'm getting an access for AAA, I would definitely want to close it. And it helps a lot. Again, it avoids posterior stick. That's again a big thing, especially if you're doing patients who are a little bit on the older side. Definitely it does. And what are the problems with ultrasound guided access? Is basically high access, right? Takes a little bit of time and of course experience. And you don't want to puncture a wrong vessel. If you have a large lateral circumflex, or if you have a very high profunda, it's very large high profunda, then it's very easy to confuse with common femorals. And especially if you're not very proficient in using ultrasound guided access, the patient has an SFA CTO, sometimes you will think the profunda is the common femoral and you will access it. That's another big thing. So how do you do it? The way I say it is always, most common miss of ultrasound guided access is if you're too close to the ultrasound. I tell all my fellows, at least go 2 finger breadths away when you're accessing it. So your needle doesn't pass the probe. You want the needle to be at the level of the probe. So you have to be 2 finger breadths away. You get at a 45-degree angle like it's shown and get it right there. And then you know exactly, that's one of the reasons why you get high access, because your needle is passing the probe and you're hitting the artery. Again, use a color flow always, and I think most of you guys are already doing it, so you are getting successful results, I'm assuming. Okay, so you can use it for vein and artery. I routinely get ultrasound guided vein access if I'm doing a venogram, because I'm putting a 10-French sheath. If I'm doing a venous occlusion device or something, then definitely I use ultrasound guided access. I never get it just based on the stick, because I don't want to put a 10-French sheath across any vessel. Again, you don't, at the inferior border of the inferior epigastric, of course, location, above the level of the bifurcation. I think these are pretty much, I have a personal feeling that almost every vessel can be accessed. That's my way of looking at it. You can access any vessel except the grafts. Even, I mean, there are vascular surgery colleagues who even access the fem grafts, and they do Postclose on it or Starclose on it. You can access anything as long as you're good at it and you have done it before, of course. Even stents should not be a problem. I think the newer stents have larger stent cells, stretch struts, unless they are a closed cell stents. Open cell, most of these stents are now open cell, so they can be accessed.
Fellows say if you have a high bifurcation, almost getting to the E1 ligament, and your SFA looks like a good 8-millimeter vessel, is there any downside accessing that?
No. If you're at the level of the femoral head, I don't think there's any downside accessing. You can still close it. If it's disease-free, if the vessel is more than 6, you can still close SFAs. Postclose can be done on an SFA. You have other devices which can be done on SFA. It's totally fine. But you have to understand the pseudo rates are going to be a little bit high. So you have to be careful about it. As long as you're comfortable, I feel like anything can be closed. So you just have to be confident that you can do it and you can handle it. If anything goes wrong, you should be ready to handle it. If you can't handle the complication, I don't think none of us have a right to do what is supposed to be done, right? So if you can handle it, sure, why not? But you can, yes. Again, manual compression. easy, right? Easy to pull, especially if you're doing 5 French or 6 French interventions. It's easy to do. But if you're doing large bore, then that's where the closure techniques come into play. So if cannot be accessed, of course, you have other sites to access. Don't forget that, right? You have others, you have radials to access. You have other femoral to access. You have antegrades to access. Now you have pedal to access. So don't push yourself to do an access because that's the only access point. There are other ways to do stuff now. Again, this is a manual thing. I'm not going to go over it. So plug-based closures, again, we're going to go over closure devices. I think you guys already know there are plug-based closures, the suture-based closures, right? I mean, they are metal-based closures. Again, every device has its pros and cons. I'm not going to talk about it. I think it's operator dependent. Some people are as an atherectomy device the same way. Whatever you're good at, you're good at. So I don't think any device is better or worse or anything like that. Every device has its own potential side effects, pros and cons. So plug-based device, again, reduced ambulation, easy to discharge, right? Collagen-based. The biggest disadvantage is when the patient starts walking, the displacement of the plug, very high. Potential issues of plug dislodgement is pretty high, and re-access in the restrictions, right? You cannot re-access anything which you do plug-based device, at least for 4 weeks. It depends on if it's angiosale, I think you can do it within 4 weeks or 4 to 5 weeks. If it's any other closure device, I think you have to wait for 6 weeks. That's the recommendation, at least. So suture-based closure devices, again, it needs healing time. That's one of the, and learning curve is the biggest thing. Again, hemostasis is attained right on the table, so you know he's not going to bleed. But once the suture takes in, it takes in, right? They're not going to bleed. I don't think I have personally ever seen suture-based closure devices rebleed from the access point, unless you've made a big track and the track is oozing. But once the suture picks in, picks in. Again, this is a point. This slide is not to mainly say some device is better than the other or anything, but definitely, if you personally ask me, I always felt like Postclose is better than any other closure device because that's good in my hands. That doesn't mean it should be better than any other device in somebody else's hands. I think every device has its pros and cons. This is more just to show how successful. I think it's because it's more widely used device. That's why they are definitely, especially with large bore accesses now. So large bore access, this has become gained a lot of popularity over time, right? There are some people who use two pre-close, two Postcloses, which is pre-close before. There are some who just get away with one. I just came to know today that some of the interventionalists do just one Postclose for a 17 French and get away with it. I didn't know that. I knew that it's possible, but some do. So again, that's great if you can. I think it's a technique you have to develop over time. But I don't, if my understanding is right, it's approved only to do it for anything until 14 French. Anything above 14 French needs another pre-close. Again, if it can be done, it can be done. As I said, it's operator dependent most of the time. It's not, the good part about suture-based devices is you can use it in veins. Veins can be pre-close too. So let's talk about what I think the symposium is being paid for by Abbott. So let's talk about Proglide. So I think how many of you guys have used Proglide? Wow, there are some people who didn't use it. I didn't know. No. So other ones, everybody else uses what kind of you guys use plugs, or how many of you guys have used Angioseal? Wow, interesting mix. Okay. Sinai has more popularity to use Proglide. I think we are more pro. What do you use? Or Postclose. So again, suture-based dealing is easy. Again, rapid hemostasis, you can easily attain it. But once it takes in, it really takes in very well. It can be used in almost any single situation, if you really ask me, unless the vessel size is less than 5. If the vessel size is less than 5, you should not use Postclose. That's my personal recommendation. I would not even touch Postclose on that vessel because there's a big chance that you will tear the vessel and shut down the vessel. Unless you're really good at it, but I wouldn't try it. Again, shorter times, hemostasis. use only Proglide in my outpatient lab. So I actually use Proglide and just discharge the patient in 2 3 hours. They can nicely walk out. I have touch wood never had any complication as of now from it in the last 8 years. So that's why I trust that device. Again, as I said, it's operator dependent, whatever you're good at. Again, cost analysis, if you see, I think this is true for any hemostasis device, external hemostasis devices. Once they have come into market, yes, there is a cost to do it, but they have reduced the amount of complications, of handling complications, and the amount of money which has been used in trying to handle complications. Definitely a significant amount. But again, at the end of the day, remember, you are paying money to do this device. So if it's not necessary, don't try it. It's probably better to just manually pull it. Again, they came up with a new device called Prostyle, right, which is more suture mediated closure device. What is the difference between the older device and this one? This is blue in color. The other one is purple in color. What? Sorry, the bad joke. But this has more tensile strength. They have these sutures. The needles are very high tensile strength. The reason why they came up with this is because they have mixed platinum-based tensile strength, especially for calcified lesions. That's why this device has been made. Very easy to go in at any angle, and also it takes on a calcified plaque much easily, and it doesn't give a lot of injury to the vessel. That's why this was brought in. How many of you guys went back after Postclose and have seen access-based pre-stenotic sites, like at the level where you accessed and you put a Postclose? If you went within 4 weeks, you saw that there was a kind of a lesion-based appearance. Okay, so I should tell you that that's completely normal. I don't think it should be treatable. That's what I'm trying to tell you. I don't think you guys should treat it. It's very normal. Some people have a delayed amount of absorption of the sutures and they have a reaction at the level of the access site. So it's very common to see that. Usually, if you go back and after 3 months, if you do an ultrasound, you won't see anything. Everything will be absorbed off of the suture. Because of the local inflammatory reaction, you see it. I'm telling you because it's very, very common to see it. Um, again, I think a lot of people have experience with Postclose. People who haven't used Postclose, I think you guys should definitely try it. I think it's worth it. This device is definitely worth the money. That I can tell you. Has a couple of things. The device itself, it has a suture trimmer. I'll go over how it's done, and the sutures are hydrophilic coated and everything, and they have a tensile strength. So they work like a suture of 8. They have a male and a female end. That's what they call it. And I'm going to show you how that device is made. So this is. Oops. So you basically introduce the device in until you get the blood flow. You have to see the blood flow out. You have to pull the device back, go back in again until you get the blood flow. Deploy the knot, pull back, and then the tensile strength comes in. They join both the ends, the male and the female end. Pull back, reintroduce in, push down the plate, device out. So at this point, a lot of people have a different ways of doing it. I don't know how many of you guys reintroduce the wire. How many of you guys reintroduce the wire when you're doing Postclose? How many of you guys don't reintroduce the wire when you're doing Postclose? Very interesting. I never reintroduce the wire while doing Postclose. I've never done it. I don't think. I think it's a matter of experience of what you do. A large bore, I think if you're doing single device, you guys should definitely. But the recommendation is you guys should always reintroduce the wire. That's my recommendation over time. I think when I was trained 8 years ago in a program, they never reintroduced the wire. But I definitely think reintroduction of the wire is the right way to do it. You protect your access site, and I think you should always do it that way. Especially if you're doing large bore ones, definitely. Even if you have pre-close, you should still have a reintroduction of wire. Once you put the knot in, see the hemostasis, make sure that it's not bleeding. Before you take the wire out, check your pulses. So whenever you get this knot in, whenever you're putting your purse string or your 8 suture in, check your pulses. Some people say, oh, you know what, it's hard to check the pulses when you're doing pedals, it takes so much time. My suggestion is you can always check the pulse right distal to the access point. If you have a great pulse right distal to the access point, you're pretty much okay. It's very, very, but classic recommendation is always check the pedal pulses, because you can always feel the profunda pulse when you're right distal to it. But if you're good at it, and if you can access the pulse right distal to it and you're comfortable with it, then you can go for it. It's reasonable.
So what I've been doing is I usually leave a micropuncture wire in, and then I do an ultrasound just to
You know,
good biphasic flow. Only if I have a TARDIS marvelous flow, then I stick a catheter back and take a picture and see.
that's fine. See, that's the biggest advantage, right? So everybody has a way of doing it. Micropuncture wire, some people use an 035 wire, but the most important point is this device gives you the advantage of reaccessing the same site. You can always put the sheath back in, you can always do manual pull, make sure you rescue your vessel. That's the biggest advantage of this device, which no other device has. So you should take the advantage of it. So again, if you're good, once you put it in, like you're putting the suture with the device, if you think that you're good, you have attained it, now tighten your knot and close it. But I can definitely tell you, once this device is deployed and you get hemostasis, it's very, very extremely rare. I have never seen an issue with it. In the last 9 years of my career in endovascular, I've never seen an issue with it. So again, post-close technique, you basically have to hold it for a little while, make sure your pulses are good. As long as you have good pulses and everything, you're good. How do you do? We'll definitely go again. When not to use Postclose, I think it's very important. That point has to be spoken about. Vessel size less than 5, no Postclose. I would not recommend it. Super calcified, if you're right through the calcified plaque with the new suture, yes, you can. I think experience-wise, saying yes, you can, but the company says no, try not to use it. But experience-wise, yes, you can use it. You can get it if you're comfortable. If you have a lot of fibrous tissue also, as long as you can find a good path, make a good track, you can still use it. So again, this goes over everything what we just said. How to do pre-close or post-close. Again, this is post-close technique. The pre-close technique is as simple as the post-close technique. You basically put it in, get the device in. Anything above 14 French, I recommend definitely go with another device. Do a pre-close. So you just don't tighten the knot. You just don't make a knot tight. You make sure both the sutures come back out. You leave it out on one end. So if you're doing two devices, most common question is how to deploy two devices. I would deploy them at least 90-degree angle. Deploy one at 45, the other one at 45 again. That's the best way to do it. Go cross, turn the device, deploy it, leave the two sutures, again put the reintroduce the wire, go back in, deploy it, turn the device, reintroduce it, put it on the side. Now what happens like that when you do it at two 45-degree angles is you have a clear path to do your intervention. Then the sutures won't come in your way. They can be on the sides. You can keep doing your thing. Once everything is done, put the wire back in, tighten one knot, see how it is. If everything is good, pulses are good, tighten the other knot, see everything is, break the sutures, come out. Very easy. It's not, I think, especially with the newer device, because it's more hydrophilic and everything, it's really, really easy to deploy this device. It's just a learning curve, but once you learn it, I think it's a fantastic device. Again, as I said, I think we went over these steps. If anybody has any questions, I'm always here till the end of the day. You guys can definitely grab me. One thing I always tell the fellows, and I think you guys should know it, is when do you have complications after you deploy the suture? Is when you have not gone deep enough. If there is a lot of fibrous tissue or a lot of calcification, you have not gone to the level of the vessel site and tied the knot. You have tied the knot in a very higher up because you feel like you're on the vessel, but you have not made your track to the level of the vessel. So they have they have another suture device. So along with the Postclose itself, there is a nice knot device which comes in. So if you see this metal thing is the same size, exactly the same size as the head of the Postclose itself. So you can actually know based on the dark lines how deep you went with your initial device when you sutured it. your tightener device should go exactly the same size. If you're not at the same side, I think a lot of people who deploy Postclose have probably not realized that. They probably just go by the feel of where they are. But if you're not comfortable, this is the definitely way to do it. So 2 needles, of course, you form a cuff. And so the reason why you have to understand this device is there's a little technicality involved in it. And the complications of Postclose usually come if you don't know the device, where the device comes, because the most common problem you have it with is cuff miss. You don't know where you're deploying your cuff. If you deploy the cuff too much deep into the vessel or out of the vessel, you're ending up with the complication again because you think you deployed it. You could have partial hemostasis, but you will end up with a pseudo or a huge hematoma. So you should know that. So potential causes of a cuff miss. Most common reason is if you have a heavily calcified arteries. I was telling you, that's why it's very important. If you see the length of this device is the same as the length of the suture tightening device, exactly the same length. If you went until this mark into the skin, the other device should also go until that mark into the skin. If you went only until this mark into the skin and just deployed the suture, that means you have left at least a centimeter of knot away from the vessel. Yeah, you might get a partial suture because you have a scar tissue or a calcified vessel. But once the patient starts walking, she's going to develop a huge hematoma or a pseudo. So that you guys have to definitely miss, right? An incomplete advancement of the plunger. If you have not advanced the plunger in completely, or you have not gotten a good blood flow, trickling of the blood from the side port of Postclose is not a good way to deploy. If you're trickling blood, don't deploy it. Pull back in, get lack of hemostasis, go back in, go in a different direction. There is no rule that you have to deploy Postclose only anteriorly. You can always deploy Postclose as a 45-degree angle, 90-degree angle. I think you can deploy it at any angle you want, as long as you're deploying in at the same angle as the vessel itself. You can't change the angulation of the Postclose when you're deploying it. As long as you're in the line with the vessel, you can turn the device in any different angle. So you can rotate it, but you can't tilt it. As long as you rotate it, you're totally fine. So if you have a calcified chunk, rotate it 45 degrees or 90 degrees on either ways, get away from the plaque and deploy it. But wait for a good blood flow. If you're not getting the blood flow, 2 main reasons. One is either you're not in the vessel at all, you're out of the vessel, and you're getting the blood flow from a small branch, or you're too deep into the vessel, so deep into the vessel that you're probably hitting a plaque and the plaque is not letting the blood flow come in. So if you deploy too deep into the vessel, then you'll catch a plaque and you'll pull the whole vessel and you will tear the whole vessel. Can you go and rescue your vessel? Yes, you can, but you'll end up with a stent. You will definitely have to stent it because there'll be a significant amount of dissection involved there. And you don't want to, and all you guys know, common femoral stenting is not the best way to go. I think Dr. Ferry spoke about it, especially if there's if there is no disease. Next is if you're way out of the vessel, right, and you deploy it, you'll again have to compress. You'll get a hematoma, pseudoaneurysm, but it might be too late by the time you realize it. So you guys have to be careful when you deploy this device. I recommend that you at least deploy at least 10 to 15 under some good supervision and then start deploying the devices. But it's worth it. How many do we let the fellows do before they start deploying by themselves? 10. So if cyanide has 10, then it's 10. So we do a lot of femoral access. So I'm telling you, I think that's probably what it is. So again, the device should not be moved. The device should be very stable when you're deploying it. That's very important. Again, when you retract, be gentle with the device. If you want to do in a rush, then this is not the device to use. This device needs a little bit of time, so you want to take your time and do it. That extra 30 seconds or a minute is going to avoid a lot of pain for you. So it's very important. So I definitely recommend that. So I think this is all. Okay. All right, I think I'm on time. Any questions? I think we have 5 minutes to go before. All good? Yeah, please. So I'm sorry, you're rewiring before you deploy. So once you deploy the first suture, right? So when you take it out, you have an access port for wire. So you have to put the wire in, keep the wire there, take the device and put the first knot. When you put the first knot in, wait for it. See, you will have a trickle of blood coming out, which is supposed to be, as long as you don't have a profuse blood flow, like arterial flow out, pulsatile blood flow, you're good. If you have good pulses, take your wire out, finally do the final suture. That's what I would do. But if you have a good arterial blood flow, there's only two reasons why that happened. Either is you completely missed it. The second way is either you just didn't make it a tighter knot. So before you think that you completely missed it, which is very unusual, what I would say is take the knot device back up, go back in, rotate it, make your nice track and tighten it. But if you feel like you tightened it and then you came out, you still have a pulsatile flow, you totally missed it. Then put the sheath back in. You can always take your suture off. You can try another device and see. Or if you're not comfortable, take a picture, make sure you didn't cause any harm, and you'll pull. Again, advantage is if you want to try another device after Postclose, you can always do it.
Sorry, what do you mean with take a picture once you remove the...
No, I'm saying if you still have the wire and you're not comfortable, you know for sure that you have completely missed it, the suture is not on the vessel, put the sheath back in, but definitely take a picture because you just don't know what you did, right? You're assuming that you missed it. You just didn't know if you missed it because it's too much into the vessel or too much out of the vessel. So you definitely want to make sure you didn't tear the vessel. That's all it is. Just for your happiness, you want to sleep overnight. I don't like to be called back again for Postclose. Not something you want to go. You want to sleep peacefully. Don't pay $300 to wake up in the middle of the night.